हाँ देख रख दे उधर चलेगा।
Good evening, everyone. Welcome to Mahamana Case Discussion Series. And we'll begin our session today with invited talk by Dr. Archi Agrawal. She is a professor, Department of Nuclear Medicine, TMH Mumbai. And her talk is on RAI therapy in differentiated thyroid cancers. Welcome, ma'am.
So, Naina, should I start?
Yes, ma'am, you can start now. And we can see the screen. Yes, ma'am.
You can see the slides?
Yes, ma'am, we can see the slides.
Okay. Good evening, everybody. So, I'll be speaking on radioactive iodine treatment in differentiated thyroid cancer. Lecture, we're going to go timing of RAI. How do we prepare for radioactive iodine? What is a pre-therapy and a post-therapy scan? RAI treatment as per risk stratification and the follow-up post-RAI treatment. Before going into the lecture, just a small input on what is I-131 and what is I-123. So what we are dealing with and what is available in India is radioactive iodine, which is labeled with I-131 iodine. What you will read in your books is 123 iodine also, but I-123 iodine is a gamma emitter. So it is used only for diagnosis and is not available in India. 131 iodine, whereas this has both beta and gamma emitter. So it can be used both for therapy and for diagnosis. And this is what we are using in India. So both for therapy as well as for diagnosis, I-131 iodine is used throughout India. I-123 is not available, though it's a good agent because it gives lesser radiation dose when you're doing a diagnostic scan. But because of non-availability, we do it with I-1 sodium iodide, which is labeled with I-131. So what are the goals of radioactive iodine treatment after total thyroidectomy? Number one is remnant ablation. What is remnant ablation? When we destroy the residual, whatever benign thyroid tissue is left behind, that is known as remnant ablation. And this will eliminate the thyroid gland, the source of thyroglobulin, and will facilitate the detection of recurrent disease by measurement of serum thyroglobulin and radioactive iodine scans. Coming to the second point, which is adjuvant therapy. Here, this will destroy suspected but unproven microscopic disease, and it is intended to improve disease-free survival and also will decrease the risk of recurrence. And RAI therapy, now this is mainly, it concerns persistent or metastatic disease, and this is given to improve disease-specific as well as disease-free survival. So basically, the goals of radioactive iodine treatment are three: remnant ablation. When you know that it's only some benign thyroid tissue is left behind and you want to make TG a very sensitive marker and also radioactive iodine scans a sensitive scanning modality, then you will do remnant ablation. Adjuvant therapy, when there is some microscopic disease that is left behind, which is just a suspicion, but you don't know exactly whether it's left behind or no. RAI therapy, when you know definitely that there is metastatic disease, you will treat with radioactive iodine, and this will improve disease-specific and disease-free survival. So if we look at the benefits of radioactive iodine therapy in high-risk patients particularly, it will decrease the local recurrence rates by about 50% of the patients, as in patients who are treated with radioactive iodine as compared to patients who are treated only with surgery. It will improve the disease-specific survival and progression-free survival in patients who have lung or bone metastasis. So if we look at the prognostic classifications of DTC, there are two. One is based on the TNM classification. The other is based on ATA risk stratification. Now, when we are looking at TNM classification, it looks at the risk of cancer-related death. So more than 90% of the patients will have stage 1, stage 2 disease, and the cancer-related death is very less than 2% of the patients will have cancer-related death because of thyroid cancer. And the ATA risk stratification, this looks at risk of structural recurrence. And if we look at the three categories that they have divided into, the low, intermediate, and high risk, the risk of structural recurrence is less than 5% in low risk patient, whereas the immediate risk category, it varies from 5 to 20%, and in high risk, the risk of recurrence is more than 20%. And as per the ATA risk stratification, more than 80% of the patients of DTC are low risk, and therefore the risk of structural recurrence is very, very low. Whereas the risk of recurrence in the intermediate group varies widely from 5 to 20%, and you should treat them carefully. So RI ablation, it should be tailored according to a risk-based approach. And the expected benefit of post-operative RI therapy depends upon the individual risk of the patient. So if we look at low-risk patients, I think you must be knowing that when we are looking at papillary CA thyroid, intrathyroidal tumors, which are less than 4 centimeters, there's no gross extrathyroidal extension, less than 5 lymph node metastases, which have just microscopic lymph nodal metastasis, absence of any aggressive histology, absence of vascular invasion, and a low post-operative TG level, all this in papillary CA thyroid are considered as low risk. Whereas in follicular CA thyroid, all patients who are well differentiated with capsular invasion and only less than 4 foci of vascular invasion, if it is present, these are all considered as low risk DTC. So what is the evidence that we have now? Retrospective studies have not demonstrated any mortality benefits of post-operative RAI. And if we look at structural disease, the structural disease persists after surgery in only 2.5% of the patients. Now, these patients, because the number of patients is so less, and the structural disease, if at all it occurs, it will occur very late. Whenever it occurs, it can be treated with further surgeries or I-131 treatment, and the risk of mortality in these patients is less than 1%. So follow-up can just be based on serum thyroglobulin levels. And if we look at the studies that we have, a large retrospective study with 1,300 patients categorized as ATA low risk, they treated the patient with radioactive iodine and did a follow-up for 10 years. And they saw that there was no significant effect of RI adjuvant therapy on overall or disease-free survival in this study with a long follow-up of 10 years. We also have 3 systematic reviews by Sauka, Sachs, and Lamartina, and they have also not demonstrated a significant effect of I-131 adjuvant treatment on disease-related mortality. So coming to some prospective trials that we have, the first of the prospective trials that were done were Estimable 1 and the high-low trials in low-risk patients. Now, because earlier the low risk were treated with 50, 100 millicuries, sometimes even 150 millicuries, they did a prospective large randomized controlled trial, which looked at treating the patient with 100 millicuries versus 30 millicuries. And the way they prepared the patient were either with thyroid hormone withdrawal or with recombinant TSH. So what they saw in this study was that the post-ablation success rates at 6 to 9 months were similar in both the groups. So whether the patient was treated with 30 millicuries or the patient was treated with 100 millicuries, the ablation success rates were similar. So these 2 studies, they showed that there was no need to treat a low-risk patient with 100 millicuries, whereas they could just be treated with 30 millicuries of low-dose radioactive iodine. Now, they also showed outcomes post 5-year follow-up, and in both these studies, both the Estimable 1 and the high-low, they showed that in this 5-year follow-up, same favorable outcome was observed, whatever the initial protocol was used for ablation. So whether 30 millicuries, 100 millicuries, or thyroid hormone withdrawal was used for the preparation, or recombinant TSH, all the 5-year follow-up was also very similar in both these studies. So coming to the next trial, the very well-known estimable trial, which was published in NEJM in 2022. And this is a very talked about trial because this was a prospective randomized phase 3 trial in low-risk DTC patients post-total thyroidectomy. So 700 odd patients, both divided into two groups. One group received only 30 millicuries, the other group received no radioactive iodine. So the primary objective of this study was to see whether no RAI was non-inferior to RAI therapy with respect to absence of composite endpoints, which were functional, structural, and biological abnormalities that were seen at 3 years. So functional means they looked at radioactive iodine scans, structural, they looked at ultrasound of the neck, and biological was TG levels at 3 years after total thyroidectomy, whether the patient was treated or not treated with radioactive iodine. So 730 patients evaluated at 3 years after randomization, they saw that there were no events in both the groups in more than 95% of the patients. So the events, whenever they saw some events, the events were more frequent in patients who had a post-operative TG of more than 1 nanogram per ml during thyroid hormone treatment. So these patients can well be controlled or followed up based on the post-operative TG evaluation, and there was no need of radioactive iodine in this low-risk category of patients. So they concluded that a follow-up strategy that did not involve the use of radioactive iodine was non-inferior to an ablation strategy with radioactive iodine regarding the occurrence of functional, structural, and biological events at 3 years. So most patients of low-risk DTC will do exceptionally well after surgery with either lobectomy or total thyroidectomy, or maybe active surveillance also, that is much talked about these days. And the disease-specific survival rates are in excess of 99%. The structural disease recurrence rates of less than 5% after either low-intensity or high-intensity treatments. So most patients with low-risk thyroid cancers are surgically cured, and outcomes cannot be improved by radioactive iodine therapy. They can best be managed with serum TG and reassurance. And that's why we say that there is no need of radioactive iodine in low-risk DTC patients. So coming to the intermediate and high-risk category, now we know that intermediate, all the aggressive histologies like tall cell variant, solid, columnar, hobnail will all come under the aggressive histologies. And whenever you have lymph node metastasis, which have more than 5 microscopic lymph nodes and less than 3 centimeters in size, they will be categorized in the intermediate risk category. High risk, we all know when there is extensive or macroscopic invasion of the perithyroidal tissues, when the lymph node size is more than 3 centimeters, where there is extensive vascular invasion, poorly differentiated CA thyroid, and elevated poorly differentiated thyroid cancer, elevated post-operative serum thyroglobulin levels, all these will come under high-risk category. So the risk of recurrence in intermediate ranges from 5 to 20%, whereas in high risk, it is more than 20%. So these are the patients who will need radioactive iodine. So in patients with intermediate, the risk of persistent disease and recurrence is higher than in patients with low-risk DTCs. And the risk of thyroid cancer related death is still low in the intermediate risk category. So heterogeneous group, and thus the protocol for initial treatment is frequently defined on a case-to-case basis. So in one of the studies which was published in Annals in Surgical Oncology, they showed that the overall survival can be improved in aggressive PTC histologies after giving radioactive iodine treatment. So intermediate risk factors with definite indications for offering RAI therapy in the intermediate risk category would be aggressive histologies, increasing volume of the nodal metastasis, and also advancing patient age. So the dose that is needed when you are treating intermediate risk of radioactive iodine would be about 100 to 150 millicuries of radioactive iodine. But this would depend on case-to-case basis. And when you have a patient where you think that the risk of recurrence is extremely low, it's around 5 to 6%, then these patients can even be treated with 50 millicuries of radioactive iodine. But aggressive histologies, we will always treat with 150 millicuries of radioactive iodine. In high-risk patients, this represents 5 to 10% of all patients of DTCs. They have higher risk of persistent and recurrent disease and higher risk of mortality from DTC. The initial treatment should always aim to eradicate all tumor foci. And retrospective studies have shown improved disease-free and overall survival after I-131 administration in DTC patients. So RAI is definitely recommended in high-risk DTC, and the dose would range anywhere from 150 to 250 millicuries. So what is the protocol that we use? So whenever the patient has undergone near total or a total thyroidectomy, if you are doing the preparation of the patient with thyroid hormone withdrawal, then we wait for 3 to 4 weeks because we want the endogenous TSH to rise to more than 30 micro international units per ml. But if we are considering doing a recombinant TSH within 1 week to 10 days, you can opt for radioactive iodine treatment. You just want to wait for 7 to 10 days for the initial inflammation that has occurred after the surgery and the scar to heal a bit, and then you can treat with radioactive iodine. And before doing a radioactive iodine, we do a pre-treatment diagnostic scan. Now, whether we do a pre-treatment or we don't do a diagnostic scan, that depends upon institute to institute and country to country. So we always prefer doing a pre-treatment scan because it tells us the presence of iodine-avid thyroid tissue wherever it is present in the thyroid, in the whole body scan. So whether it is confined to only the thyroid bed or it is present anywhere else. So it will give us an idea about what disease the patient has. And so we always prefer doing a pre-treatment diagnostic scan. After doing a scan, based on the risk category, the patient will be treated with radioactive iodine. When we are treating with more than 30 millicuries, the patient goes into an isolation ward. Less than 30 millicurie can be treated on an outpatient basis, and isolation ward is not needed. Once the patient is in isolation and once the radiation level is below a certain level, then the patient is brought out of the isolation ward. Once the patient is brought out of the isolation ward, then we do a scan, which is known as the post-therapy scan. Now, post-therapy scan in a patient of CA thyroid treated with radioactive iodine is very, very important because we have treated the patient with anywhere from 50 to 200 or 250 millicuries. And this post-therapy scan, that is a very sensitive scan because we have given so much of radioactive iodine. So this should always be done. And in children, this is very, very important because sometimes in children, you think that the disease is just confined to the neck or only has lymph node metastasis. But when you have given a higher dose and you do a post-therapy scan, you see that the lung metastasis are picked up and you see diffuse lung uptake, which was not seen earlier. So post-therapy scan is one of the most sensitive scan in a patient who's receiving radioactive iodine and should always be done. So coming to the pre-treatment diagnostic scan before radioactive iodine ablation, now we have prepared the patient's TSH is more than 30. Now, when we are doing a diagnostic scan, we can either do with 100 microcurie, or 1 to 3 millicuries, or 3 to 5 millicuries. Now, 100 microcurie is very less dose and does not give us any, so you can only image the neck with it and does not give any whole body information. So at present, it is not followed anywhere. And 3 to 5 millicuries when we are doing, it can be associated with stunning when you are giving a dose more than 5 millicuries. So we don't want stunning also to occur because that will reduce the effectiveness of radioactive iodine once we are treating the patient. So we don't want stunning and we want whole body information. So the best bet for us is to give 1 to 3 millicuries of radioactive iodine, which will give us a whole body information and will also not cause stunning. So how do we prepare a patient? The prerequisites for radioactive iodine treatment are a TSH stimulation of more than 30 and a low iodine diet. This will enhance the uptake of radioactive iodine and thus it is done. So TSH stimulation, it can be done either endogenously or exogenously. Exogenous, we give recombinant TSH, which is the thyrogen, which is widely available now. And you give 2 injections, 24 hours apart, 0.9 milligrams IM. On the third day, you can treat the patient directly, and on the fifth day, you will do the TG estimation. And once the patient is out of isolation, you will do a post-therapy scan. Whereas when you are doing endogenous stimulation of TSH, you either stop L-troxin, or that is LT4, for 3 to 4 weeks, or you stop LT4, switch to LT3, which is now available in India and is under the brand name of Linorma, for 2 weeks, followed by withdrawal of LT3 for 2 weeks. Now, why do we switch to LT3, that is Linorma? Because your hypothyroid symptoms will be much lesser when you're putting the patient on LT3 and withdrawing only for 2 weeks before giving the radioactive iodine treatment. So the quality of life is very much enhanced when you are tweaking it like this and giving LT3 or Linorma. So for a pre-treatment scan, the checklist, you will check TSH, which should be more than 30. You will look at the serum TG, which is a stimulated TG now, and anti-TG antibodies. Because if your anti-TG antibodies are positive, your serum thyroglobulin estimation is not reliable. Therefore, you will always do a anti-TG antibodies with serum TG estimation. Pregnancy, lactation, these are contraindications for treating with radioactive iodine. So even lactating mothers, if the patient has delivered and is lactating, you should stop the lactation, because patient should not be breastfeeding after giving radioactive iodine treatment. So you stop for 3 months, but by that time, the patient will stop lactating only. And there should be no iodine interference. So for that, we have we should ensure that the patient is on a low iodine diet as recommended for 2 weeks prior to giving radioactive iodine treatment. And the amount of, it should always be a low iodine diet and not a no iodine diet. So low iodine diet is preferred, and it should be less than 50 microgram per day for dietary iodine. So what will you stop? Avoid all iodine containing agents, IV contrast. Prior to surgery, what is done is absolutely fine, because by that time 4 weeks would have passed, and that's absolutely fine. Otherwise, seafoods, vitamins, some expectorants contain iodine, some drugs which contain like amiodarone, Lugol's iodine or povidone iodine, all this should not be given prior to giving radioactive iodine. So always check labels, and if it contains iodine, please do not give that medication to the patient. So once we have given a diagnostic dose and we do a pre-treatment diagnostic scan, what we can see is we will either see only a thyroid bed uptake or uptake outside the thyroid bed. So only thyroid bed uptake, that means disease is confined to the neck, or we are just maybe doing ablation for a remnant thyroid that is present. So treat the patient with 30 to 100 millicuries. If there is uptake outside the thyroid bed, which could be metastatic, that is in the lymph nodes or in the skeletal metastasis or in the lung, then you treat the patient with higher dose depending on what category of metastasis the patient has. So lymph node metastasis, small size lymph nodes could be treated with 100, whereas lung mets would need 200 millicuries, and skeletal metastasis we would treat with 250 millicuries of radioactive iodine. So what are the approaches for choosing the dose of radioactive iodine? Now, there are 3 approaches. What we generally follow is the fixed dose approach, but there are other tools also. One is the tumor dosimetry, that is quantitative. So you try to estimate what is the how much amount of radioactive iodine is going to the sites when you're doing a diagnostic scan, and this could be done with an agent which is I-124, which is used for tumor dosimetry, and that is a PET agent. So I-124 labeled sodium iodide, which is used for tumor dosimetry. So you calculate what is the expected amount of dose that you want to give to the tumor site, and based on that, you calculate the dose, or based on maximum tolerated dose. So using the upper limits based on the blood and the whole body radiation absorbed dose to the lungs also, you can calculate the dose. But all these 3, whether you're doing a tumor dosimetry or going by the maximum tolerated dose or using a fixed dose approach, they all have similar they yield similar results, and therefore the fixed dose approach is favored, because that is easy, it's not cumbersome, you don't have to do so much of calculations, and you can directly treat the patient with whatever amount of radioactive iodine that you have planned for the patient. So coming to this fixed dose approach, when we are doing a remnant ablation, anything from 30 to 50 millicuries would suffice. If the patient has nodal metastasis anywhere from 100 to 150, aggressive variants will also receive 150 millicuries, whereas lung mets we would treat with 200 millicuries. And if the patient has skeletal metastasis, we would prefer treating the patient with 200 to 250 millicuries of radioactive iodine. So to show you some examples, now this is a 42-year-old lady, PAPSA thyroid with lymph node metastasis. So comes under intermediate risk category. We did a diagnostic scan and you see that there is increased uptake only in the thyroid bed. What other things that you're seeing, that is just the physiological uptake that you're seeing. Now this is an anterior scan and this is a posterior scan. So you're seeing some uptake which is confined only to the thyroid. So this is how the radioactive iodine is given. It's a liquid dose. The patient takes it via a straw, or sometimes it can be in a capsule and the patient will take the capsule. So it depends from where we are getting. It could either come in a liquid form or a capsule. Now this is a fume hood which has a negative pressure, and this is needed because iodine is volatile and you don't want the stuff to get irradiated with radioactive iodine. So this is a fume hood which is, has a negative pressure, and that's why a liquid vial is kept under it and the patient drinks the radioactive iodine. And this is how the patient is monitored in a isolation ward. So this is a gun monitor which will look at the radiation level that the patient is, and that the patient is discharged. So every morning the patient is monitored with this radiation monitor. So this patient, we have done a post-therapy scan, and you see that again, you are seeing increased uptake only in the neck, and rest all is physiological uptake. So there's no metastatic side, and you are just seeing the neck uptake. Now, this is how the scan would look if the patient has lung metastasis. So diffuse uptake, and there was also some thyroid bed uptake. Some mediastinal nodes were also showing uptake, and these were all metastatic disease. And this is a patient with skeletal metastasis, so has skull showing the thyroid bed uptake and multiple other sites of disease in the iliac bones and elsewhere in the body. So now this was a patient who was treated with radioactive iodine. This is a pre-treatment scan. You see the post-treatment scan. The patient has intense uptake in the thyroid bed. First follow-up we do at 6 months, and you see there was some uptake. The patient was treated again, and on the second follow-up, there is no uptake, and this patient was completely treated after a second dose of radioactive iodine. So how do we do TSH suppression during follow-up? So in the high risk, you would need a higher TSH suppression in the initial phase till the patient is treated. Otherwise, then the TSH level can be kept in the normal range. In the intermediate also, in the initial 6 months, you will put the TSH in a lower limit, and later the patient can be put in normal TSH dosage. Low risk category, there is no need of any suppression, and the patient can be in TSH in the normal levels of TSH. So how do we follow up these patients? So the first, we follow up with I-131 scan, that is at 6 months. We do a thyroglobulin estimation. We do anti-TG antibody. Serum calcium estimation is always done, because once the patient, before putting the patient in an isolation ward, we don't want low calcium levels or tetany or anything of that sort. So we always measure the serum calcium and a USG neck, particularly in patients who have lymph node metastasis. So once we have done a scan at 6 months follow-up, we can have a normal radioactive iodine scan, and the TG can be undetected or maybe less than 1 nanogram per ml. So this is excellent response. A stimulated TG of less than 1 nanogram per ml. Excellent response. So we just start the patient on T4 and follow the patient yearly for a TG estimation. The other category would be abnormal uptake on a radioactive iodine scan, and the TG is raised. So we know that this is structural incomplete response, and this patient would need to be treated again with radioactive iodine and then followed up subsequently. Other category that we can have is a normal radioactive iodine scan where the TG is raised. So this is biochemical incomplete response. So measure the TG after 3 months, and if it's still rising, then again, we repeat a radioactive iodine scan, because we want to see whether this was due to iodine interference, and we want to rule out iodine interference. So you do a radioactive iodine scan, and again, if it is negative, then this patient will be labeled as tennis and this patient will be labeled as tennis and you will plan to do an FDG PET CT, MRI or CT. It's always better to do an FDG PET CT because it will give you a whole body information and you'll see the entire spectrum of disease that is present, and this will help you to triage the patient. If the disease is confined to one site and which can be operated, the patient can be offered surgery, otherwise external RT. And if the disease is at many places and there's metastasis, then the patient will be treated with tyrosine kinase inhibitors. So what are the contraindications and side effects of RI? I'll just take 2 more minutes to finish. Is it okay?
Yes,
Yeah,
ma'am.
yes, ma'am, please continue. No issues. Please continue.
Yeah, okay. So what are the contraindications and side effects of radioactive iodine? Pregnancy and breastfeeding, I already told you. These are absolute contraindications to RI therapy. And in men who receive a cumulative dose of more than 400 millicuries of radioactive iodine, may have temporary reduction in sperm counts and infertility. So this normalizes after a few months. I think, we give a lot of importance to female pregnancy and breastfeeding, but we forget men. So always men should be counseled that when a patient is receiving 2 or 3 doses of radioactive iodine, when it goes up to millicuries, there will be temporary reduction in sperm counts and that which could lead to infertility. But this is only transient and it will normalize after a few months. So after 6 months or so, it should be absolutely normal. So side effects to RI treatment are very few and in most cases always transient, but some patients will complain of pain in the parotid glands and xerostomia also. So these patients, what we do is always after giving radioactive iodine, 24 hours after giving radioactive iodine, we tell them to suck lemon or some candies so that the salivation is increased and these patients don't have this problem of xerostomia or pain in the salivary glands. So the risk of developing second malignancy after radioactive iodine, we talk about it, but then though it is present, but the incidence is very, very small. So once we have treated a patient with radioactive iodine and we do a whole body scan at 6 months, and when we are seeing this, we know that the patient there has been successful remnant ablation. Now, what is successful remnant ablation? When you don't see any visible uptake. Now, sometimes you may see some uptake here, but based on that basis, you should not go ahead and treat the patient again with radioactive iodine. You should always look at the TG. If your stimulated TG is less than 1 nanogram, though you are seeing some uptake here, you should just follow the patient on a serum yearly basis on a serum TG evaluation. So here you're not seeing any uptake. So absence of any visible RI uptake on subsequent diagnostic scan, or when the uptake, sometimes we calculate the uptakes, but most, institutes might have that uptake probe that we have in our institute, but your private centers, they will not have any uptake probes and they will not calculate the uptakes, though it can be done on a gamma camera also, but they are not very, reliable, the uptakes. But if you have an uptake probe and you're doing it, uptake less than 1% or absence of uptake and undetected stimulated serum TG of less than 1 nanogram per ml, when you have this, you know that you have successfully ablated the patient. So the take-home message would be you should should take care to see that the patient is adequately prepared for a radioactive iodine therapy. Your TSH should be more than 30. You could do a thyroid hormone withdrawal, put the patient on Linorma or with recombinant TSH. And also a low iodine diet is preferred 15 days prior to giving radioactive iodine treatment. So treatment with radioactive iodine, low risk, RI is not needed. In the intermediate risk, as per risk stratification, you will treat the patient anywhere from 50 to 150 millicuries. In high-risk patients, you will definitely treat these patients with radioactive iodine anywhere from 150 to 250 millicuries of radioactive iodine. TSS suppression would be as per the risk stratification, and follow-up would be with whole body iodine scans, serum TG estimation, anti-TG antibodies, and a neck ultrasound. Thank you very much, and I would be very happy to take any questions that you all have.
Thank you very much, ma'am, for such an informative talk and sharing your expertise. Are there any questions for ma'am? You can put it on the chat box. And now let's proceed with our case discussion. Ma'am, I would request you to join our panel of examiners for our
Sure.
case presentation next. And today's case presentation will be presented by Dr. Rajesh Roshan. He's an MCH resident from BBCI Guwahati. And our examiners for today are Dr. Deepak Balasubramanian. He is Professor, Department of Head and Neck Oncology from Amrita Hospital, Kochi. Dr. Poonam Joshi, she is Professor, Department of Head and Neck Oncology from ACTREC, Mumbai. And Dr. Ashok Das, he is Professor, Department of Head and Neck Oncology from BBCI, Guwahati. Welcome, everyone. And Dr. Rajesh, you can share your screen now.
Good evening, madam. Is my screen visible, madam?
Yes, it is visible.
Good evening, everyone. Today I will be presenting case on differentiated thyroid carcinoma. My patient is 25-year-old female, a resident of Shillong, Meghalaya, who is the dad of government office bearer of health department. She came with a chief complaint of swelling in the front of the leg, towards midline, extending to the right side since 1 year. History of presenting complaints. My patient was apparently well 1 year back when she noticed a small swelling in front of the leg of size about a month. It gradually progressed to the within size of average volume. So it is not associated with any pain. No history of there is a history of gradually increasing in size. There is no history of difficulty swallowing, breathing, or any voice change. There is no history of any excessive sweating, heat intolerance, palpitation, diarrhea, tremors, or weight loss. There is no history of food intolerance, constipation, lethargy, or weight gain. No history of cough, hemoptysis, or any bone pain. Past history, there is no history of diverticulitis, hypertension, allergy, asthma, or tuberculosis. There is no history of any past surgery. No history of any radiation exposure. Family history, no history of any thyroid malignancy or thyroid-related disorder in the family. Coming to personal history, she takes a mixed diet. That bowel habits are normal. Sleep is normal. She doesn't complain of she doesn't say any addiction. She uses iodine salt. There is no change in appetite. She is a postmenopausal woman. To summarize my history, my patient is a 75-year-old lady from Meghalaya with approximately 4 centimeter anterior neck mass, which is asymptomatic, regularly increasing in the anterior part of the neck, extending to the right side since 1 year. It is not associated with any compressive symptoms or symptoms of any hyper or hypoparathyroidism. So from the history, I can sum up. It's a midline most probably arising from a thyroid. Can be either a benign or a malignant thyroid. We can be more clear when we do a proper examination. However, the size usually points out towards the kind of malignancy, but we'll have to rely on clinical examination and other tests as well.
Is there any significant family history?
Sorry, sir?
Any significant family history?
No significant family history, sir. No any complaint of any thyroid disorder in the family, the near family, or in the neighborhood also.
So, what are the syndromic thyroid swellings that you know?
What are the symptoms of?
Syndromic thyroid swelling.
Yes, sir. Syndromic are we can see the Cotton syndrome is there's the PAP syndrome is there's a associated with the Mint syndrome are there, sir.
And no, there's Cowden's complex, this and that.
Cardinals complex is there.
Yeah, yeah, okay. So there is you have to, family history is very significant. The question would be, what are the syndromic uh, DTCs or what are the syndromic MTCs? That will be the only question relevant in this history. Yeah,
Shall I proceed, sir?
please proceed.
Rajesh, just a minute.
Please.
Deepak, I just want to ask him. Can you hear me, Rajesh?
Yes, sir, yes.
So suppose when a patient with thyroid swelling come to your OPD, in history, what are the things you wanted to know from the patient? Which are you, as a head and neck surgeons, are looking for in a patient with a thyroid swelling? When a patient come into your OPD, obviously you know that this is a thyroid swelling from a first sight only. So what are those things you wanted to evaluate from the patient? What are the things in history part is important for you?
Sir, I would like to know the site duration, any associated symptoms with it, and along with that, family history, sir.
To be more precise, when a patient comes to with a thyroid swelling, you obviously know that this is a thyroid swelling. What strike in your mind? Which
So,
point? Suppose if I am asking you to pinpoint only a single question, then what you will ask?
duration, sir.
See, correct. So why duration?
Because in the thyroid, aggressive variety of malignancy are known to progress very fast and cause various kind of life-threatening symptoms to the patients. So it is very important to
Correct.
know from that point of view what kind of histology the patient is having.
Correct. So Rajesh, to just highlight this point, when a patient come to in your clinic with a thyroid swelling, so we all wish as a head and neck surgeon that this should not be the anaplastic one or poorly differentiated, which has a very short history. So invariably we'll try to evaluate that history. Okay?
Yes.
Yeah, go
So,
ahead,
hi,
proceed.
Rajesh, Dr. Poonam here. So, I just wanted to ask you, like, how common or how strong is this familial association in DTCs? So, Dr. Deepak asked you about the syndromic association with PTCs. I'm asking you the familial association with PTC. Like, you know, your medullary carcinomas, they have high predilection for to run in families. Is it similarly common in PTCs also, papillary thyroid carcinoma?
In papillary thyroid carcinoma, it is less than 1%, madam. But in medullary, it's around 20%.
Okay, so where did you read
Not-
that? So where from what data you're quoting?
Madam, there is
Okay. So usually the familial association with PTCs is not as strong as medullary carcinomas. Okay. So usually whatever, like if you read the ATA guidelines also, the first line they write is that the familial DTC per se. So how do you say that the patient has familial DTC? It runs in the family. What criteria it has to fit? Because for medullary, we know there are fixed criteria. Okay. So how do you say in PTCs that it is running in family? So what symptoms, what signs, or what molecular findings you are going to find out?
two first degree relatives affected with that disorder, madam. Along with that, early age onset.
So that's why I'm saying, so two family members. So one of the definition is that two family members, when they have PTCs, it can be just by chance also. So it can be just sporadic also. So in familial DTCs, actually it is not very clear. Actually, this association is not very clear actually in PTCs, because if it is like it can be in up to 60% of the cases, it can be just sporadic if two people are involved. It just happened that one patient developed and like one person developed and the other also developed after a while. Moreover, we know in females it can be more common. So that I just want to convey that here the association is not as strong as in MTCs. Go ahead, Rajesh.
Just to add on, Poonam, you are
Yes,
very
sir.
correctly asking this question. So, Rajesh, from symptom, can we just predict that this could be a familial? What Poonam is asking, like suppose 2 or 3 member has, developed thyroid cancer in that family. From symptom, is there any way we can make out that this could be a familial, not sporadic?
So apart from the early age of onset, I don't know about other things. Then with the early age, will be early onset.
Your voice is not very clear, Rajesh. Can you just go a little away from the speaker? Something? Can you
Yeah.
please repeat your answer?
So all I'm saying is, when only one sign of family onset is I know is the aggressive variety and it's early onset.
Correct. Yes, mostly it is the aggressive variety in the families. Okay, go ahead, please.
Thanks. So coming to general examination, patient was examined after taking a due consent in a well-illuminated with patient sitting with the patient in sitting position, patient average and build, well nourished. Peacock score is 1. Gray hair, no loss of pupils, no icterus or pallor, clubbing or healing. No eye signs of hyperthyroidism are present. Pulse rate is 72 per minute, regular, volume. Respiratory rate is 14 per minute. Blood pressure is 110 upon 70 millimeter of mercury. Upper abdomen examination is soft, not tender. Forward is present. What's is normal? The root tremors noted. No other rescue was noted. Coming to local examination on inspection of 5 by 4 centimeter globular. Smooth swelling present on the entry part of the neck, extending superiorly.
So, Rajesh, go to the previous slide. Why you did the per abdominal examination? How does it correlate with the thyroid carcinoma, suspected thyroid carcinoma?
Well, thyroid carcinoma suspected, we don't know whether it's a family variety or a sporadic variety. So, if it is associated with polyposis syndrome or carcinoma of the intestine colon and all, so we will find distended and abdomen like that. If the liver is involved somehow, we may find a that as such. So, upper abdominal examination is usually important in syndromic diseases, as in case of thyroid.
Okay, go ahead.
So in local examination, 5 by 4 centimeter globular, smooth swelling present on entry part of the neck, extending superior to the thyroid, inferiorly 1 centimeter above the suprasternal notch, laterally posterior part of sternum to the muscle, and medially reaching up to the midline. Skin over the swelling is normal. It goes to the deglutition. It does not move with the tongue movement. No other lymph nodes were palpated or involved vein piercing or no they were very visual pulsations. When burden sign is negative, Trachea phase to be deviated to the left side. There was no scar seen on the neck. Shall I move on? Coming to palpation, inspection findings were confirmed on palpation as regard to size, shape, and position. So 5 by 4 centimeter globules swelling present on entry part of the neck. Superior to thyroid notch, inferior 1 centimeter above the suprasternal notch, laterally into the posterior part of sternum. Middle left to the midline, temperature of the skin is normal, there is non-tender, smooth, uniform inconsistency. I was able to get below the swelling. Skin over the surface is pinchable. No palpable lymph nodes were there. Trachea was shifted to the left side. Covers test and was negative. Capillary pulsation were felt on both the sides. On Hopkins examination, I found bilateral mobile vocal cords. Systemic examination, cardiovascular respiratory system were examined and were found to be normal. Shall I move on or? Am I audible?
Can you just show the, can you just repeat the palpation finding?
Palpation findings, yes.
Yes.
So, inspectory findings were confirmed on palpation as regards to size, shape, and position.
No, just tell me what are the things you look for in palpation. That's all.
Pardon, sir?
Just tell me what are the things you look for in palpation.
Palpation, I look for the consistency, the extent, when if it is attached to or fixed to any structures in the neck, and if there are other swellings in the neck as well.
So how do you find this attachment to other structures in the neck?
So when we move the thyroid gland horizontally in position, if it is really
You can't move the thyroid gland. You can only move the thyroid cartilage.
Pardon, sir?
You can't move the thyroid gland. You can only move the thyroid cartilage.
Yes, sir. Yes.
So
Yes, sir.
how do you identify visceral involvement or vascular involvement on palpation?
Vascular involvement in cases of if the carotid is involved, we won't feel the carotid pulsations as such.
If the carotid is involved, you won't feel the carotid pulsation.
The carotid pulsation are feebly felt, sir. That's a very sign.
Okay. Okay. Then what else? So you said you confirmed the inspection. You have to talk about the margins of the swelling also, whether it's well defined or irregular. You didn't talk about the margins of the swelling. Obviously, if it's not a well defined swelling, you can imagine it to be infiltrated. How do you make out strap muscle involvement on palpation?
I'll ask the patient to tighten the sternum if the swelling can be still palpated.
I asked strap muscle. I didn't ask sternum. See, basically in palpation, you want to see whether there is any extrathyroidal involvement. So what are the clinical signs on palpation that signify extrathyroidal extension, that show extrathyroidal extension?
The hardening consistency, firm to hardening consistency, involvement of the skin. And
how many thyroid cancers, DTCs have you seen involving the skin?
None, sir.
Then, have you read the diseases of thyroid clinical examination for extralaryngeal extent? How to identify strap muscle involvement? What is the sign that is pertaining to the vascular involvement? Is the carotid more involved in thyroid malignancy, or is the IJV more involved in thyroid malignancy?
IJV.
So how do you make out if the IJV is involved in thyroid malignancy?
And Burton's how it works.
Pemberton is, even if you have a large goiter going retrosternal, you will have positive Pemberton. How else will you do it? You ever read Randolph's examination of thyroid, no? The 4th or 5th chapter in his book, Clinical Examination. That should be the entire basis of your clinical examination. Okay, so you in palpation you look. So this is just very basic thing. This is nothing great. So in palpation, size, shape, margins, consistency, vascularity, increased vascularity. Did you mention about Brui and did you auscultate the thyroid in this patient?
Yes, sir. I did auscultate. There's no Brui.
You didn't mention that in the palpation. Did you mention it, or I might have missed it?
Yes, sir, I didn't mention it, but I did the auscultation parts.
But you didn't mention it, correct?
Yes, I did mention it.
So you have to mention that also. Why is that significant?
Yes.
Hello?
Yes, sir.
So read this clinical examination from Randolph very well. It's or the clinical signs very well, because these are basic things. Anyway, proceed.
Yes.
And you said bilateral vocal cords are mobile, no? What are the reasons for vocal cord immobility in thyroid swelling?
In thyroid surgery or thyroid disease, sir?
Yeah, tell me the reasons why there is vocal cord immobility in patients with thyroid disease.
Because of the involvement of the recurrent ganglion nerve,
Okay.
one thing, because of the direct extinction or direct infiltration of the larynx and involvement of the one side
How many patients of DTC have you seen, even the advanced DTCs, even anaplastic, when the cartilage framework is involved, the cords are still mobile?
yes.
That's not the answer. There are three reasons for vocal cord immobility in thyroid disease. What are the three causes?
So
Again, I'm
one
basing all my things on what I've only read Randolph's book, so I based all my things what's given in his book. So, what are the three? One, you said nerve involvement. Okay,
nerve
next.
involvement, sir. And there is
That
the
is
posterior.
direct involvement of the nerve by the tumor. Okay, second.
Listen, recurrent joints, sir.
Recurrent joint never comes in the picture of thyroid. Second, what is the second cause? So you have to stage your answer. So one cause can be neuropraxia because of compression of the nodule over the recurrent laryngeal nerve. Second is direct involvement of the nerve parenchyma by the tumor. What's the third cause? You can have vocal cord immobility due to praxia, right?
Yes, sir. Yes, sir. We can.
And you can have by nerve parenchymal involvement, you can have vocal cord. What is the third cause? Anyway, read the causes for vocal cord immobility. And you obviously have to differentiate it between. Anyway, carry on. We don't have too much time. Yeah, carry on. Carry on.
To summarize my case, I have a 76-year-old female patient with right side thyroid nodule, 5 centimeters, smooth, firm, mobile, well-defined borders, progressive, not associated with any pain or any other symptoms. There is lack of any hypo or hypothyroid signs or symptoms in the patient. So most probably from the history and from the examination, I may say my patient might be having a benign or a malignancy of the thyroid gland. Just because the swelling is progressive since for the last 1 year, it wants more towards the malignancy. But on the other hand, I didn't find any invasive symptoms of the malignancy.
No. Don't give an essay answer for your diagnosis. What is your diagnosis? Then the question will come after.
My diagnosis is the malignancy.
I would just give the diagnosis as a solitary thyroid nodule on this side for evaluation. That's all I would give my diagnosis. Why you can't have a benign nodule coming up in 1 year? Who says that's what are your reasons for malignancy? Only because it is growing over 1 year.
Yes.
But none of your clinical examination or other history points to malignancy.
Yes.
So if you say this is malignancy without any ancillary procedures, that shouldn't be correct, isn't it? So this is a solitary thyroid nodule or a multinodular, whatever you get, for evaluation. That's all. Don't commit whether it's benign, malignant, and anything. Let the examiner ask you, okay, why don't you think this is malignant? Then you say the only fact pointing towards malignant is that she's an elderly female with a 1 year or short duration history of thyroid swelling. Why is it benign? Because there are no other signs of malignancy starting from history, starting from clinical examination, no lymphadenopathy, consistency doesn't seem to feature, and all the other findings. So this is a solitary thyroid nodule for evaluation. That's all. That's how I would give the diagnosis. I'd ask the other two examiners to share how they would expect their students to give a diagnosis.
Yeah, I completely agree with Dr. Deepak. Rajesh, you can't say that it is a malignant lesion because there's no such fixation of cord which goes in favor of dysphagia or any hard fixed mass, nodes I think at least in the history, nothing of this sort was there. So it is just a thyroid swelling. And like Dr. Deepak rightly said, you always have to say that this is a thyroid swelling under evaluation. It can be a benign swelling also. I completely agree. And I always teach students at our center also to think it in that and present as well.
Yes, sir.
Thanks, Poonam. Ashok sir, how else would you like this diagnosis to be given?
Yes, yes, yes. I absolutely agree with you, Deepak. Yes. By now, as also rightly Poonam has said, there is no such symptoms that from so far we can firmly say that it's a malignant. Yes, I totally.
And you have to understand one thing. Earlier, there used to be prognostication data, the ages, AMEs, all those scores used to be there to signify what is malignant, what has a higher risk. See, in thyroid, everything is risk associated, okay? All our diagnostic modalities are risk stratifications only. Nothing is absolute data. The only absolute data that you have is final histopathology. It's not like squamous cell carcinoma or whatever other carcinoma. Whatever scores we are using, ultrasound or FNA, they're all risk stratification scores. They don't give absolute numbers. The only absolute diagnosis is histopathology. So unless you have proper history, I agree with you. If you have proper history and proper findings, you can be definitive. But this to me is a solitary thyroid nodule under evaluation. Please proceed. What would you do next for this patient?
Well, first, the patient should be, I will do a thyroid function test for this patient, sir. Followed by ultrasound and ultrasound guided FNAC as well, sir. So, the patient.
Go on. So you said you want to do. So be flashy about the way you answer. Okay, you have to. So you want to do biochemical tests. You want to do imaging modalities, and you want to do histological diagnosis. So your biochemical tests are obviously thyroid function tests. What is the significance of thyroid function test in a solitary thyroid nodule?
Sir, it tells us whether any nodule is hyperfunctioning or hypofunctioning, so that we can plan our management as per the nodule, and we can.
No, that's not the answer. Which is more significant for malignancy? Is the euthyroid status associated with malignancy? Is hypothyroid status associated? That's how your answer should be. Based on the TFT, when we do the TFT, if my results are euthyroid, this is it. If my results are hypothyroid, this is it. If my results are hyperthyroid, this is it. You have to have that clear definition in your mind.
If the nodule is hypothyroid, has more chances of being a malignant as compared to the hyperfunctioning nodule.
So a hyperfunctioning nodule can be autonomic or can be diffuse disease, correct? Very true.
Yes.
If you have hypothyroid, you can have autoimmune Hashimoto's also. Or what else can you have? So what does the TFT allow you to decide for?
Decide for FNAC. Whether we have to go for FNAC or we have to go for a radioactive scan.
Okay, very good. So you understand that if the patient has a hyperthyroid status and you suspect autonomous nodule or grades, okay, that's very great, very, very good. So ultrasound, next step is ultrasound. So why not do CT? Why is ultrasound better than CT for upfront evaluation of thyroid nodules?
Because ultrasound can characterize a nodule, while the CT scan cannot, and ultrasound has greater sensitivity as compared to the CT scan as far as the lateral the thyroid and lateral networks goes. So, to characterize the nodule.
No. What is the key point? Why is ultrasound better than CT scan in the evaluation of thyroid? What is the key point?
Sir, to characterize the nodule and to know where to take the FNC from.
No, you're correct. But can you fine tune that answer?
To guide our FNC and to characterize the nodule as per the risk category of parents.
No, there is something inherent to the thyroid and carotid tissue that makes it favorable for ultrasound. What is that?
It is the surface, it's very near to the surface. So ultrasound can easily detect has a high sensitivity as compared to the CT scan.
No, Ma, there is a specific thing. So you're right, you're mostly right. So CT scan is first of all a static image, okay? And thyroid generally takes up contrast, okay? So you will not be able to make out whether the nodule is spongiform, solid, or cystic on a CT scan. All you will get is a rim-enhanced lesion. So the echogenicity of the lesion is what makes ultrasound. You need the echogenicity of the lesion to guide the ultrasound. That is the first principle, okay? Because thyroid is a spongiform tissue. You need the ultrasound and the echoes to define what is the character. Okay, so how do you grade your ultrasound findings?
So it is graded to carrots category carrots 1, 2, 3, 4, 5. So we have to on the basis of the characteristic of a nodule, the echogenicity, the margins, microcalcifications, taller than wider shade.
Microcalcifications, no? Microcalcifications.
I said
Yeah, okay.
microcalcifications. So microcalcification. So it takes into consideration all these characteristics of a nodule, and we can into a direct group. So 1, 2, 3 are the low groups. 1 and 5 would be highest groups.
Okay, good. Please go ahead with the ultrasound finding.
So in ultrasound heterogeneous nodule measuring 58 by 62 by 42 millimeter in the right lobe of thyroid with foci of calcification. Trachea mildly deviated towards the left. Low extrathyroid extension was noted. Low vascular encasement of cell infiltration. Left lobe is normal in size and ecotexture. Cystic nodule 2.5 millimeter seen in left lobe, which is colloid nodule, no neck node, pussy, and a direct category 4 was given to the nodule.
What is the inherent problem of the rat spore?
Inherent problem, pardon?
No, what is the inherent problem of the rat spore?
Thyroid spore. So
Yeah.
it falls somewhere between the very highest category and low category. So low risk category.
No. Specific answer. What is the inherent problem of the rat spore? What is the percentage of malignancy for the rat spore?
Sorry, sir, I don't know that.
No. Have you read any white paper on what is the risk of? So this, okay, we'll come to that later. So this was the rat spore. Okay, go to the FNAC finding.
So FNSC was reported at papillary carcinoma CA thyroid. This is the 6 categories.
Oh, okay, that's good. Yeah. Ashok sir, Poonam, do you have any comments to make about the rat spore?
Yes. Rajesh,
Sir,
hello.
yeah, sir, no
Yeah.
comments from my side. Sir, actually, I have an emergency. Some patient is having chyle leak. The plastics are waiting. I'm sorry, I will have to leave. I have to go to attend the emergency.
Go ahead, Poonam, no problem.
Okay, sir. Thank you.
Yeah.
Bye, Poonam.
That's fine.
Thank you. Thank you.
Okay,
Rajesh, go ahead.
Yeah, go ahead.
Yeah, Rajesh, go ahead.
Ashok sir, in the rat spore, do you?
No, that's fine.
Do you,
That's fine.
okay,
Deepak,
sir.
you have already almost covered everything. Yes.
Yeah, please go ahead.
So CT scan was done for the patient. So CT scan was reported at overt thick bone solid cystic mass. The region looked for 5 by 4.2 by 6.2 centimeter in size, compressing right towards right without intervening. Calcific focus is seen in the medial aspect. Mass effect upon strap muscles, sternocleidomastoid muscle, inferior. No evidence of paradynamia evolution. Isthmus and left lower lying in order, and there were no neck mode reported.
This is abnormal.
So
Why
what
did
is
you
it?
do a CECT for a straightforward case where there was no, do your iodine specialists, do they recommend doing something like this for a patient who might need radioiodine ablation later? What is the consensus? Why did you do a CECT first? What was the indication?
So the lesion is more than 4 centimeters, that is 6 centimeters in size. So
So you're saying size criteria is the reason for your CECT?
And also, sir, we wanted to see the central compartment also, sir, which was largely covered by the habit behind, sir, to decide whether to go for the.
So your logic is CECT is used to evaluate central compartment in a patient who has nothing else.
Actually, sir,
that is your logic. That is not correct. That logic is not correct. How do you assess for central compartment? Why ultrasound can't pick up central compartment? No, justify your CECT in this patient. If you say for central compartment, that is not the answer. Do you have any other reason?
It's a T3 lesions of more than 4 centimeters, and as per the
okay, tell me the evidence. Tell me the evidence where it says if it's more than 4 centimeters, you have to do a CT scan for upfront evaluation.
And just to add on Deepak's comment, Rajesh, as because this is a T3 disease, so anyway we need to address the central compartment. So how it is additionally helping? Rightly, what Deepak is asking. Tell us the real purpose of doing a CT scan, how it accomplishes or how it helps the ultrasound finding.
The CT scan is complementary to the ultrasound of the leg, sir. In ultrasound, in cases of big thyroid glands, like more than 4 centimeters, there might be possibility of retropharyngeal, parapharyngeal nodes, even the mediastinal nodes, which we cannot see on ultrasound. So in a T3 T4 lesion, basically we need CT scan to evaluate for these areas as well.
So how it is?
Your logic is not correct. So the only place where you use CECT for evaluation in a DTC is if there is extensive lymphadenopathy, you want to screen the upper mediastinum also. Second, if you have visceral involvement. Third, if you have vascular involvement. These are the only, this is evidence-based. So this is the only reasons why we do a CECT in these cases. Otherwise, I wouldn't do. But because you've already done for this case, it doesn't matter. So how does this affect the post-op radioiodine ablation?
Cases anyway, the patient has to go for a radioiodine ablation, sir.
No, what
so
he
do
is
you need to
asking
saturate all the sodium iodide synporters?
Sir, sodium iodide synporters, the studying can be there, sir, but in the dosage of 1 to 3 millicurie, it might not be there. And anyway, in the 4 to 4 weeks time, all the iodine is excluded from the system. So by the time patient goes for iodine, I don't think the patient will have any problem with the uptake, sir.
Correct. Yes, Rajesh, absolutely. Even if you do a CECT, that is pre-surgery, if you are doing a CECT, that contrast will not interfere with the radioactive iodine treatment or the scan that we do, because when we are waiting for 3 weeks, by that time most of these contrasts are water soluble valuable contrast. So they are all washed out from the body by weeks. So if we are giving radioactive iodine after 3 weeks or later, 3 to 4 weeks, then there is no problem in doing a CECT. Now, what you were saying about 1 to 3 and causing stunning, CECT will not cause stunning with that. Something you said about stunning. Please come
No,
back.
no, I
on
didn't
that.
talk about stunning. Dr. Shanmusundaram, who's
Rajesh was saying.
our
Yeah.
Dr. Shanmusundaram, who's our nuclear physician here, he always has a lot of
Yeah, yeah.
papers. ATA doesn't have, ATA very clearly says that it doesn't affect anything.
Dr.
ATA is very clear about that, and we have evidence
Yes.
to talk about it. But there is
Absolutely.
no data, there's no long-term data. See, we don't give, what we give is empirical I-131 therapy. We don't do dosimetric. We don't see the urinary clearance of the contrast. We don't do any of those things. So he feels that there is a potential problem because we don't do dosimetric ablation. We do empirical
Correct.
ablation. So we really don't know any of the, I mean, I'm not a nuclear physician. This is Amrita's protocol. We never do a CECT because
Okay.
Dr. Shanmusundaram doesn't like if the contrasted iodine is given. We don't measure iodine excretion. We don't do all the tests that should be done before a patient has ablation or scan after a prior CECT. But ATA is very clear. There is no interference. So
Yeah,
there is no
Deepak,
problem.
yeah. We have been like, in TMH, we have been treating patients who have undergone CECT, and most patients will undergo CECT prior to surgery, but we have never seen this. And there's a paper in NEJM also where they have, it came out, I think, in 2012, 13, something, somewhere like that, or 14, where, they have looked at the urinary iodide and they have compared 1 week mein kitna tha, 2 weeks, 3 weeks, and 4 weeks, and they have said that by 3 to 4 weeks, all the iodine that is given in the crust excreted out of the body. So we always do, and there's no need to measure urinary iodide actually. If we are doing a diagnostic scan, tell you whether there is iodine interference or no.
I completely
Because if
agree.
you're seeing some
This is
uptake in the
just an
neck or
institution. Yeah, this is
that
only
would
an
be-
institution protocol.
Yeah.
I completely
Yeah.
agree with you.
Correct.
ATA is very
Uh,
clear about it. But I still
Yeah.
don't have his reason for doing a CECT on this case.
Yeah,
So,
that's absolutely fine.
Deepak,
That's not my area. So that you all.
hello. Yeah. So, just to have a comment, like Deepak, we also feel that it's nothing to do with a CCT because the time period we wait for it's more than enough to clear those things. And coming back to Deepak's question to Rajesh, Rajesh, why he was repeatedly asking the purpose of doing a CT scan here? Is there anything to do with a mapping of the disease?
Yes, sir. Mapping of disease is very important. So that's why the CCT was done in the first place. Because it's a big lesion, sir, 6 centimeters.
And another disparity with the ultrasound that in tube group, sometimes ultrasound may miss some 10 to 15% of the small nodes in the tube group, which is overlap under the thyroid lobe. So in that part, CT scan helps a lot identifying those nodes also. Anyway, please continue, carry on.
Yes. So my diagnosis, as per my clinical examinations and all the sonographic and cytological examination that we have done, it's a papillary carcinoma therapy, 2023 and 0 and 0 stage 2 disease.
Okay. So how you will counsel your patient for treatment decision?
Sir, I'll counsel this patient for total thyroidectomy with a single compartment recurrence surgery, sir. The patient has to be counseled very well regarding the pros and cons of the surgery. She must know and understand that removing the whole thyroid gland, she will have to be on paraxin for the rest of the life. She also has to understand the risk of injuring the recurrent laryngeal nerve as well as the parathyroid glands. This thing she has to know, and also that she will have to be under surveillance and due to the age factor, she might undergo radioactive therapy as well. So she should be willing to come on a regular basis, follow up to the hospital with the investigation will be repeated every time she visits the hospital.
Just tell me in one sentence, what is the extent of surgery that you'll do for this patient?
So we will do a total thyroidectomy with a right sided central compartment clearance.
Yes, Rajesh, as because it's a T3 disease, there is no doubt of the extent of the thyroid surgery. But what about you have mentioned for central compartment, but when you will address the lateral compartment, lateral neck?
So lateral compartment has to be addressed when they actually biopsy proven node in the lateral compartment, and the second part is that if we have a large bulk nodes in the central compartment, present in the central compartment.
Okay.
So, what is the adequate yield of a neck dissection in a DTC?
Sorry, sir, I don't know about this.
Sorry?
Sorry, sir, I don't know about this.
No, there is a
Oh,
diagnostic yield for SEC when you do 18 nodes or something, I think. So, what is it for lateral neck dissection in a DTC?
what is the extent of neck dissection, Rajesh? Just tell that.
I'll go for a 2, 3, 4, 2 to 5 levels, sir.
Sorry,
You'll do
2.
2 to
Why
5. You'll do 2 to 5
Yes, sir.
in an N0 neck as an elective neck dissection.
2, 3, 4. Sir. 2, 3, 4.
But why 2, Rajesh? Which are the most commonly affected level of lymph node in lateral
Yes, sir. Yes.
lateral?
Yes, sir. There are 22% in papillary carcinoma thyroid, sir. Rather than from the upper to the skip metastasis to the level 2 and level 3. That is all.
But commonly which group?
Commonly 3 and 4, sir.
Ah, correct. Commonly 3 and 4. And as this is a N0 neck, will you go to explore the level 2 where the nerve is there?
Sir, 2A, not 2B, sir.
Okay, but that's not necessary.
So you have to understand what are the indications for a prophylactic neck dissection in thyroid. Tell me the indications for a elective neck dissection of thyroid.
Elective neck dissection, we will do the central compartment. We have to one of the advanced disease, T4 disease, sir.
So in T4, you will do elective neck dissection. Is it? What is the evidence for that?
Central level 6, sir. Level 6.
Okay.
Level
Okay,
6.
you'll do level 6 exploration and then you will decide. Tell me what are the indications for an elective neck dissection in a DTC? Very flimsy indications, nothing proven.
Elective neck dissection and DTC, the lateral neck dissection.
Yeah, elective neck dissection means lateral neck dissection, not central compartment.
Yes,
so,
sir. If there is a presence of bulky lymph nodes in the level 6 central compartments.
So if you have bulky lymph nodes in central compartment, you'll do an elective neck dissection.
Yes, then they have to explore the lateral compartments.
No, I didn't ask whether you explore. You said you'll do a neck dissection. So what is the evidence for that?
It's not proven yet, sir. Not proven, sir.
There are papers looking at association. Tell me at least 1 or 2 of those papers.
Yes.
One which showed association with micromets, one which showed no association. Tell me those 2 papers.
Sir.
Okay, we don't have time. So in this patient, you do a total thyroidectomy, central compartment exploration, bar dissection of the central compartment. If you find positive nodes in central compartment, you might consider lateral compartment neck dissection. The evidence for that is very flimsy, so all that is fine. So what is your after your thyroidectomy? What are the ways to identify the recurrent laryngeal nerve?
The recurrent laryngeal nerve is found in the Beer's triangle, sir. In the
No, there's a inferior approach, there's a lateral approach, there's a superior approach. You really have to read Randolph's book because that categorizes everything. So, what is the inferior approach? What is the lateral approach? What is the superior approach?
So the lateral approach is when we separate the sternocleidomastoid and the stratum sensor.
No, absolutely wrong. What is the lateral approach? What sternocleidomastoid you're talking about?
So we approach the thyroid from laterally, sir.
Correct. We all approach thyroid laterally only. But what is this lateral approach of identifying the nerve? Anyway, read those three things and read about the relation of the inferior thyroid artery and the superior parathyroid gland, its relationship with the recurrent laryngeal nerve. Okay. Now tell me the different classifications of the superior laryngeal nerve. There are three classifications. Tell me the three classifications.
Superior laryngeal nerve to pass the way it passes it can be the Sernia's classification, sir, and modified Sernia's classification also. Modified
Okay. Second
Sernia's
one.
It's a modification of Sernia's classification when they
No, Cernia is fine. After Cernia, what is the other two classifications? What are the other two classifications? There are three.
Yes, sir.
Three classifications for superior and general. Okay, forget that. Tell me what are the anastomosis between the recurrent and what are the different branching patterns of the recurrent laryngeal nerve?
Recurrent laryngeal nerve can pass.
Tell me the name of the classification first, and tell me about the anastomosis between the RLN and SLN.
So the classification it talks about is whether it can pass anterior to the inferior thyroid artery or this.
No.
That
That is not the focus of the classification. How do you classify? There are three. So you have to look at extralaryngeal branching and intralaryngeal branching. Okay, there are two different things. Tell me the types of extralaryngeal branching and the types of intralaryngeal branching. And tell me the three types of anastomosis between the RLN and SLN. I will send you my PPT. Send me your email ID. I'll send you my PPT. Okay.
Yes.
So RLN identification. Okay. So what is parathyroid? How do you identify parathyroid by autofluorescence? Tell me what are the ways to identify parathyroid? Subjective and objective ways. Subjective and objective ways. Yeah.
Subjective is by looking at the various clinical landmarks, that is the recurrent laryngeal nerve, particular plane. So the sphere would lie dorsally.
No, if you read Randolph's book, he will say color, size, consistency, position, relation. You have to talk like that. So
Yes,
color will be salmon colored, it's ovoid in shape, it has a leak of blood vessels, it's related. So you have to talk like that. Color,
Yes.
size, position, consistency, vascular leash, everything you have to talk like that. Tell me what are the objective ways to identify superior parathyroid and its vascularity?
Indocyanine green diaster, you can use that, methylene reducer, and by amino.
No, objective ways. Tell me about parathyroid autofluorescence.
We have to inject the dancer.
I said autofluorescence. I didn't ask you about erylic. I asked you autofluorescence. There's a difference between autofluorescence and injecting anti-expansive drugs. I asked you autofluorescence.
near infrared spectroscopy, sir.
Tell me the principle of erylic. How do they identify why is parathyroid autofluorescent?
Sorry, sir.
No, like you said, there is one way of injecting angioexpansive drugs to highlight the vascularity. And there's another way of just using autofluorescence with a specific spectra to identify the parathyroid. Tell me the difference between the two, and what is the study that recommended this erylic for parathyroid identification?
The in autofluorescence we use the nearest infrared spectroscopy, sir. While in the cases of injectable, we can use an ultrasonic.
What are you saying about infrared? I don't understand. That is not part of autofluorescence. What is autofluorescence of the parathyroid? Okay, so today's lesson is identification of parathyroid, subjective and objective. Okay, please read that. Please read that. Because there are a lot of techniques that you can objectively identify the parathyroid and preserve it during the surgery. Okay, tell me what is the blood supply of superior parathyroid?
Inferior thyroid artery, sir. But in some cases, it can also be supplied by the superior thyroid artery.
You can't answer like that. It means both are correct. Which is the higher percentage?
Higher percentage inferior thyroid artery, sir.
Who says that? Who says that? How did they find that out? Okay, for a successful thyroid surgery, how many parathyroids have to be visually identified and preserved?
2, sir.
Who says that? Give me the evidence. I'm saying 3. I'm saying 3. I have evidence for 3. So you are saying 2. Tell me what is the evidence. And how do you confirm that what you've identified is you can't snip it and send it for frozen, you can't cut it and float it in saline and then reimplant it? It doesn't work. Okay. So please learn identification of recognition nerve in 3 planes. There's a caudal plane, there's a cranial plane, and there's a sagittal plane. So you have to know the 3 planes of identification of recurrent nerve. And parathyroid, what are the subjective and objective ways to identify? Okay, so you have done surgery for this patient. What will you do next after that? It's a T3.
We'll have to wait for the histopathological reports, final report, so we can categorize the patient.
This is a T3. I said this is a T3 DTC.
Yes, it's a T3 disease, sir. It will fall in the intermediate categories, sir. So we can say the age of the patient, so which is 76-year-old, advanced age, sir. We can put the patient for RDN scan if we find any residual. We can go for radioactive ablations.
Rajesh.
Sir.
Okay.
Please go ahead, Dr. Das.
No, Rajesh, just I wanted to ask, when you do thyroid surgery, we mostly give our attention are there in the recurrent laryngeal nerve and the parathyroid. Which is more important for you?
Parathyroid, sir.
You please establish.
So the incidence of parathyroid injury in the following hypocalcemia, long-term hypocalcemia is way more than the recurrent laryngeal nerve injuries, and seeing on the if the patient has the hypocalcemia, she'll have to be on thyroid medication for a long time. That will again attract so many comorbidities in the patients, including renal failure and
So why parathyroid is so important for you? Okay, these are the result, but why parathyroid is so susceptible for injury?
Because parathyroid looks very similar to the fat tissue cell, and also it's precarious blood supply, which is very fragile, which can be very easily damaged even if you identify the parathyroid glands correctly.
Okay, what else? There are some other more regions, na? By position wise, inferior and superior parathyroid, is there anything like that?
By positions, superior parathyroid lying ventrally and dorsally to the nerves.
Correct. So what I wanted to tell you, the superior are almost constant in position, but it's very difficult to look at the inferior, or you are not been so sure about the inferior. Plus the issue of neck dissection, central compartment, and all other issues. So that's why the parathyroid get more importance during thyroid surgery than the recurrent laryngeal nerve. Anyway, Dr. Archi, please go ahead with your question.
No, I said before planning radioactive iodine, would you look at the histopathology?
Yes, ma'am.
So we have the histopathology. Do we have it?
No, sir. No, ma'am. We still don't have it.
Okay. Because, I mean, based on the histopathology, I agree that the patient is 75-year-old, so you would consider, giving radioactive iodine treatment. But the amount of radioactive iodine that you will give, that will depend upon the histopathology. Correct?
Yes.
Okay, in this case, would you do a pre-ablation low-dose radioactive iodine scan, or would you just ablate? And there are two papers from UK. I'll talk about that later. So, would you recommend a low-dose scan to see, and then a high-dose ablation, or you just go ahead with an empirical high-dose ablation in this patient?
You have to look for a low-dose scans first before going for a high-dose patient.
So that is the thing in your institute. So what is the low-dose scan?
The low-dose scan is when we give 1 to 3 milligrams to the patient and do the scans at 131.
So what is the reason why you get that low dose in
Low
this
dose.
patient, a T3 patient?
Low dose is the first to know if there is remnant ablation, second, know if there any metastasis or any remnants.
That is absolute. You will not, with a 3 to 5 millicurie patient, you will not see lung metastasis or distal metastasis. You will not see that. That will be only obvious after the post-therapy scan. Correct me if I'm wrong. You'll only see that after you give a ablation and do a post-therapy scan to see for any other uptake elsewhere. You think with a 3 to 5 millicurie iodine scan, you'll be able to find metastasis? I'm not aware of this. I'll ask the esteemed nuclear physician to tell us about this.
Dr. Deepak, actually we do a higher, even with 1 to 3, if there are metastases, you will pick up. I only said that Sometimes it happens in children that we don't pick up lung metastasis, which are picked up in the post-therapy scan. But definitely, as you rightly said, the post-therapy scan, that is the most sensitive scan. But it is not that if we are using 1 millicurie or 3 millicurie or 5 millicurie, we'll miss the metastasis. There are high chances that you're going to pick up. And that's the reason why we are doing a scan, so that we know whether the uptake is only in the thyroid bed or it is elsewhere in the body, so that we can categorize whether the patient is metastatic or not metastatic.
So that is the answer you have to give in your exam. There is a definite role for a diagnostic scan before the therapeutic ablation. Previously, if you look at the papers from UK, if you look at the papers from America, all of them, not previously, recently they've all said that the low dose scan doesn't pick up any of the distant metastasis because it's just too low a dose. But that is not true. What Madam has said is absolutely correct. We have to do a low dose scan, and then we can therapeutically adjust the empirical dose for the high dose scan. Now, tell me, what is the role of thyrogen in ablation? Thyrogen, recombinant TSH.
Recombinant TSH, sir. So, to do a scan, so the TSH level must be more than 30, sir. So, in certain patient, we have to wean off the patient for 4 weeks to attain the level required for the scan. So, if the patient has some morbidity for which we cannot wait for 4 weeks, or if the patient is a psychiatric patient, then we give a recombinant TSH to increase the TSH level so that we can do our scan before the stipulated times.
So, do you know the 2 NEJM patient papers from UK which showed it's non-inferior to iodine withdrawal versus thyrogen?
No, sir, I'm not aware of this.
No, when you're taking some...
Yeah, so, Dr. Deepak, go ahead. I just wanted to tell him that
sorry.
it is the
Sorry, please go ahead. I'm very sorry. Please go ahead. Please go ahead. You're the expert here. Sorry, I'm just talking out of clinical experience. Sorry, please go ahead.
No. Yeah, so I mean, I just actually, if he would have heard my lecture in that, we have shown that there were 2 prospective trials, no? The estimable one and the high-low trial, in which they were given 30 and 100 millicuries, and the patients have been prepared either by thyroid hormone withdrawal or recombinant TSH, and they have shown that they have equal efficacy.
Yes. So, if thyrogen is a very, very, very viable alternative to withdrawal, it has no inferior results to that. And my question is, how do you decide which patient deserves what dose in the iodine ablation? This is not to Madam, this is to the presenter.
Yes, sir. So, for the low-risk patient, if at all giving iodine, sir, they will require a 30 milligram dose, sir. If no metastasis is there, sir, if there is a remnant in the neck, sir, about 100 milligram, metastasis to the lungs require 150, and in the bones it requires 250 milligrams.
Okay. So, how much is the maximum cumulative dose of radioiodine that you can receive? In lifetime.
Cumulative dose is 1,000 milligrams.
How much?
Cumulative 1,000 milligrams.
Okay.
Madam,
so
is that a bit too high?
Yeah. So if you read the ATA guidelines, they will say 800. But
800,
in India, what we follow is about 1,000 to 1,200 also. If we are seeing that there's a benefit to the patient, only then we go ahead with 1,000 or 1,200 millicuries. Otherwise, 800 is the dose.
Actually, in America, now they have, most of the centers don't go above 600 milligrams. So, tell me, what are the long-term side effects of radioiodine ablation? What are the incidence of second cancers? Do you know anything about that? If you read Mazzafiari's book, Madam, have you read Mazzafiari's? If you read Mazzafiari's book, there's an excellent chapter on radioiodine ablation. And they talk about a lot of papers which have looked at, these are all not causal. They are associations. They are not causal. It's not that the radioiodine cause. Do you know any of those papers which have shown other primaries after a long time of radioiodine ablation?
I don't know. If there is cause.
Madam can answer that. Madam can answer that.
Okay, so wherever there are sodium iodide symptoms, one is the leukemia, so these hematological cancers, and wherever we have this sodium iodide symptoms, so stomach or in the bowel or whatever, so you should say that GI malignancies and stomach cancers, these are or breast also will express sodium iodide symptoms. So these are the cancers which can be seen after giving radioactive iodine, but the incidence is very, very low. One more thing, Rajesh, I wanted to tell you, when someone asks you that, how much radioactive iodine will you treat with? So first you should say, I will first, after seeing the HPR and everything else, I will categorize the patient into low, intermediate and high risk.
Correct.
And
Risk
then
stratification. Risk
you will do the
stratification.
risk stratification, and then you will decide on what is the dose. Okay, so if it is a low risk patient, you can just get away with not giving radioactive iodine. Or if there is a need, like, maybe you're not sure of the vascular invasion, not sure of the lymph nodal metastatic site, if it is not microscopic, or your pathologist has not mentioned, then you can say that maybe you can treat with 50 millicuries or 100 millicuries. So you have to go ahead with that, say risk stratification, where the patient falls, and then you will say how much you will treat with.
Madam's point is extremely correct. Post histopathology, you have to do a risk stratification. Now, there are two risk stratification. One is for the radioiodine adjuvant treatment, and the second risk stratification is for your thyroid suppression or follow-up.
Yes.
Do you understand? There are two risk stratifications. One is for the radioiodine, and the second is for the follow-up. Now, madam will give 50 or 100 for this patient because it's T3, large volume disease. She'll give that. How would you like to follow up this patient?
The patient has to be followed since intermediate category. So if it falls within intermediate category, the patient has to be followed for the 6 monthly to 1 year with scans, USG, thyroglobulin level, TSH level, and thyroglobulin levels.
No, be very clear. What is your investigation after 6 months? You'll do an ultrasound neck just like that.
After 6 months, sir.
Your routine follow-up is to do ultrasound neck just like that. It doesn't depend upon the thyroglobulin value.
The TG level, LPTG level, the TSH level.
Okay, if your TG level is less than 2, you will do an ultrasound neck.
LPTG also has to be done, sir.
Sorry?
LPTG levels.
Yeah, anti-TG, antibodies, all that is normal, and your TG levels are less than 2. So you will still go ahead and do an ultrasound neck.
If the clinical condition normal, sir, we don't need to go.
Sorry, I can't hear you. Sorry.
If our clinical examination is normal, sir.
Yeah, you won't do,
the
right?
TG value you have, no? When your TG value is low, so everything
So
is
we don't
pointing
need-
that there is no need of anything, right?
Yeah, the
Until unless
radioiodine
Yeah.
is taking care of everything.
thereof.
The radioiodine is taking care of all the disease that we have left behind. That's the big advantage. So you have to stratify okay, in this patient, this is intermediate risk group. How much would you want to suppress the thyroglobulin?
The intermediate group we suppressed into the thyroid, the TG or
Suppression you're doing for TSH only, Baba. You're not
No,
suppressing the
correct. Exactly. What madam is saying is correct. We are talking about TSH. Sorry?
0.1 to 0.5.
Yeah, correct.
0.5. Okay, that is correct. Okay. I'll give you, we'll finish this because it's getting late. I'll give you an example, and madam also can answer to this question. Okay, you answer, then madam will give her expert opinion. Let's say after 6 months, we are finding a high level of TG. Our neck cross-sectional imaging is negative. Do you understand my point?
Yes, sir.
High TG cross-sectional imaging of the neck is negative. How would you approach madam for further evaluation?
So if
We know there is functional disease somewhere in the body. How do you approach madam for a subsequent evaluation? There's no
So,
disease in the neck. Absolutely no disease in the neck.
it's a biochemical non-responsive, sir. So we'll repeat TG in 3 months time again, sir. And if it is still high, sir, or it's increasing, sir, then we'll say that it's a test that thyroglobulin elevated. Non.
No, I'm not. I'm saying patient comes to you at 6 months with thyroglobulin high, 500, 600, no structural disease in the neck. What would you approach your nuclear physicians with? What would you ask them to do?
A nuclear scan, sir.
Sorry?
Iodine scan, sir.
Madam, please contradict that statement.
Okay, so you know what sir is asking is that you have your TG high, but there's no structural disease. So your radioactive iodine scan is not showing anything, but your TG is high. So what can we do for this patient? If we have ruled out iodine interference, we will do a FDG PET to see whether there is disease elsewhere, right? Anywhere else, like, FDG PET then will help you to triage the patient whether the disease is in the neck or elsewhere in the body. Your TG is high and your radioactive iodine scan is normal. So first you have to rule out iodine interference. So one thing you can do is call the patient again after 2 or 3 months with proper indications as to what he has to stop and everything about iodine interference and all those things. You have to stop all the drugs, repeat a scan. And again, if your scan is negative, but your TG is still high or is showing a rising trend, then you should go about do a FDG whole body scan. That will tell you do your disease mapping and will tell you whether the disease is restricted to one side or there are metastatic disease. And based on that, you can then treat the patient with surgery or with systemic TKIs.
Ma'am, you're correct. I want to ask the presenter. Like ma'am said, we do the FDG PET and we find a source of distant metastasis. What is the role of empirical radioiodine therapy in these patients? I am assuming that you know what is the definition of tennis and flip-flop mechanism and all that. So
Yes.
we have a site of this. Sorry, ma'am?
And also refractory CA thyroid. I mean, there are 4
refractory.
definitions to refractory CA thyroid also. So
Yes.
all those you
So
should be knowing. You
tennis
can go
and-
and read. Yeah.
Yeah, refractory and tennis you need to know. So,
Correct.
ma'am, thank you. I think it's getting late. So the
Okay.
basis of a thyroid case is about how you identify critical structures. Like Ashok sir said, how to identify parathyroid. You have to look about dystrophic calcifications and why it is bad. When I did my PG in Jitmar, during my MS, I have seen many young children who were operated for thyroid where this was the children were in 80s, 90s operated. They all came back with lens calcification because of the ectopic calcium that we used to provide them. And in those days, there was no hormonal therapy. So you've got to be very careful about these ectopic calcifications and things. It can cause pancreatitis, it can cause lens problems and all that. So learn what is risk stratification, learn how to identify critical structures post treatment, during the operation, learn to risk stratify post-op. Like ma'am said, learn about the radioiodine therapies that we have, learn about Tennis syndrome, and learn about refractory Patriot thyroid because they were also different. And thyroid is always about the post-op. There is no pre-op questioning in thyroid. Do you understand?
Yes.
It's all about the post-op, intra-op question. So I think we covered a lot of diffuse topics, and I think you presented really well. So just spend some more time in. Please read Randolph's book about examination and all of those things. Azim, can we wind up?
Yes, sir. Thank you so much, sir.
I think it's quite late. It's almost 8 o'clock. Was the discussion adequate and the points raised adequate?
So the discussion was really good. Actually, it covered most of it. So we were thinking of breaking this topic into several smaller topics. But yes, overall, this everything has been covered very well in this one.
Yeah. Thanks, Azim.
Thank
Thanks to
you.
ma'am
Thank you so
from.
much, Archie ma'am.
Thanks,
Dr. Deepak.
I
Thanks,
haven't
Rajesh.
introduced
Enjoyed.
myself to the nuclear physician. Ma'am, I'm Deepak from Amrita. I'm sorry, I've
Yeah,
never
I
met
got you. I got you. I'm Dr. Archi Agrawal, Dr. Deepak.
Archi, thank you so much for entertaining me. And I have never met you in person, but I hope to meet you soon sometime.
Yeah, sure. I'm there in most
Sorry.
of the FHM ISTS program. We'll
Okay.
meet.
Sorry if I was overbearing or anything, but
No, I enjoyed.
it's
Totally
just-
enjoyed.
it's
I
just
also
like-
learned.
It's just academic things. I like academic things a lot. So thank you so much, everybody. Thank you. And well presented. And I hope you pass out well. And I hope you don't have me as your examiner also. So it should be okay.
So thank you everyone for joining. And the next session will be on the 5th of September and it will be on the laryngeal cancers. So we will be.
Azim, can somebody send me one email address where I can email my laryngeal reinnervation PPT to everybody?
So you can share it on the Mahamana Head Neck Oncology email. I'll share the email to you.
Just
From
send
we
that.
can share, yeah, and we can
I
share
will
it
talk
there.
about all the anastomosis. Then I have a separate PPT on identifying the parathyroid objective, subjective. Then I have recurrent thing and this and that. It's all a couple of presentations, but I can upload for everybody to see.
Sure, sir. Sure, I'll
And if
share
they
it.
can use it, I have no problems with anybody using anything. It's all the same.
Thank you. Thank you so much, sir. Thank you,
No
everyone.
problem.
Thanks.
Thank you, everyone.
Nice it
Thank you.
was.
Thank you, madam. Thank you. Thank you so
Thanks,
much.
Dr. Deepak.
Thank you.
Rajesh, well
Bye.
presented, Rajesh.
Yeah.
Read whatever the sir has told you to read.
Yes.
Hey, you only know 1%. I also knew only 1% when I was doing MCH, but there's so much to read. So go ahead and read all the other stuff.
Yes. Thank you.
Yeah? Yeah.
Yes.
Great.
Thank you.
Yeah. Bye, Da. Bye, everyone.
Thank you, sir. Thank you, everyone.